Hi, everyone, and welcome to our lecture about joints. So, joints can be grouped into three different categories based on their structure, function, and motion. So, that's how they're classified, that's how they're categorized by structure, function, and motion. So with structure, we're looking at how exactly they're held together. Some joints are fibrous, they have fiber tissues that hold them together. Others are cartilaginous, which is exactly what it sounds like. And then we have synovial joints, and that is synovial fluid is like this thick fluid found in most common type of joint in the body, which we will talk about a whole lot more. And they contain this little pouch of synovial fluid. But anyway, moving on. We'll talk about each of these individually and where they're located in the body. Joints can also be classified by their function, so how much movement it is. Anytime you see arth, A-R-T-H, just know that you're talking about the joint. So we have synarthroses, which are immovable joints, so like skull sutures. We have amphiarthroses, which are slightly movable, so think intervertebral joints. Think about, your vertebrae and how you can move your back with, slightly movable, but not, you can't do anything crazy or outrageous, at least for the layperson. And then diarthroses. So these are freely movable. So think joints of the elbows, joints of the knees, things like that. And then another way that we classify joints are by their motion. So the direction of movement, how they move. So if you need a refresher on this, I have added a couple slides to the end of this lecture. And you can also go back to our major themes lecture with anatomical position and motion back in chapter 1. So if you do need a refresher on all of this, you can go back to both of those because you are going to have to know motion for the quiz, and we'll talk about it just a little bit here. So direction of movement, motion, we have gliding, so that's a flat bone sliding over another bone. We have angular motion, so flexion, extension, hyperextension, abduction, adduction, circumduction. We have rotation, which is spinning on the long axis, so think ball and socket joints. We'll talk about ball and socket joints here. Also, think about what you would do to reach backwards to throw a ball. That's rotation, spinning on the long axis. Supination, pronation, so that's forearm only. So remember, anytime I say like only something, it'll probably show up on the quiz. But anyway, supination, pronation, those are only our forearms. So supination, holding a soup bowl. Pronation is going to be the opposite of that, right? Dorsiflexion, plantar flexion, that's the foot only. Inversion, eversion, that's the ankle only. Protraction, retraction, so that's the chin. So think about like if you were going to force an underbite, that's protraction, and then retraction would be bringing that back. Elevation, depression, so that's the jaw only. So open, when you open your mouth, that's depressing the jaw. When you close it, that's elevating the jaw. Opposition, that is touching your thumb to each finger, so your thumb to your forefinger, thumb to your middle finger, all of that. Here is the refresher there. So flexion, decreasing the angle of the joint. Extension, increasing the angle of the joint. Dorsiflexion, flexion of the ankle toward the dorsum of the foot. So look at this picture, that's dorsiflexion. Plantar flexion, flexion of the ankle toward the plantar surface of the foot. So the plantar, right? Think about a plantar wart that's on the bottom of your foot. That would be going towards the bottom of the foot. Lateral rotation, medial rotation, that says medical, that should say medial. Abduction, away from the midline. Adduction, toward the midline. Circumduction, spinning from one end 360 degrees. Opposition, first digit to another digit. Reposition, first digit to anatomical position, protrusion, jut jaw forward, retraction, return jaw normal, elevation, raise superiorly, depression, lowers inferiorly. I think I said that was jaw only. That's protrusion, retraction is the jaw. Elevation, depression isn't necessarily jaw only. That can be anything that you're elevating, depressing. Inversion, first foot digit up and plantar flexed. Eversion, first foot digit down and dorsiflexed. Supination, first digit up, so sup bowl. Pronation, first digit down. So look at these images to kind of help you see eversion, inversion, opposition, reposition, circumduction, 360 degrees, lateral rotation, medial rotation, abduction away, adduction into. Same here, abduction, adduction, supination, holding a bowl of soup, pronation, the opposite. So the way that I remember it the best is with the imagery, but if you are somebody who likes the explanation, then I would suggest making note cards to remember this. Otherwise, if you remember the image and what happens, you shouldn't be confused about what happens if you get asked about this on the quiz. And then I'll have more images on the end of this lecture as well. Okay. So let's go back and talk about some fibrous joints. So fibrous joints. We have sutures, syndesmoses, and gomphoses. All right, so sutures and cranial bones are fibrous joints. They're short little fibers, as you can see in that image. So that's what makes up the sutures of our skull. Syndesmoses, so that's, think tibia to fibula. It's the long ligament that keeps those two together. It prevents them from separating. So see over here. So those are those fibrous tissues. And then gomphoses. So gomp rhymes with chomp. So remember, those are going to be in the face, chomping with your face. But those are the small fibers that hold the teeth in our tooth sockets. They're called periodontal ligaments specifically. And again, gomp rhymes with chomp. So gomphoses, teeth, sutures. You know, we just learned about sutures in the skull. And then syndesmoses will connect the tibia to the fibula, the radius to the ulna. That's that ligament that keeps them together. All right, cartilaginous joints. So C-H-O-N-D. So if you ever see that chondro, I guess we could do, there we go. You ever see that, know that we're talking cartilage, okay? So here we have synchondroses, so hyaline cartilage. So this is in the epiphyseal plates. So remember, those are our growth plates in kids' long bones. So right here, growth plate right there, growth plate right there. That's hyaline cartilage. It's also going to be between rib number 1 and the manubrium of the sternum. And then we have symphyses. So starts hyaline, goes fibrocartilage, and those are going to be our facet joints and our pubic symphysis. So pubic symphysis is in the front that makes part of the pelvic girdles right here. And that's fibrocartilage, holds that together. It provides stability to the pelvis, and it does give it some limited flexibility. So why would you need flexibility there? Think about labor and delivery, right? Pelvic girdle is going to have to be a little bit flexible to get that baby pushed out of there. So those are our cartilaginous joints. And then we have our synovial joints. These are the most common and the most movable types of joints, right? So these are going to be characterized by the presence of a cavity filled with a synovial fluid, and that is what allows for free movement between articulating bones. So what does articulating mean? To articulate just means to form a joint or a connection between two bones, right? So if you hear something is articulated, like there's a skeletal articulation, that means that's a skeleton with all the connections between it formulating that skeleton. It's not a disarticulated bone, which is an individual bone, right? Anyways, okay, so structure. Synovial joint structure is always going to contain a cavity that has fluid in it, and it is going to be encapsulated. So it's going to have a capsule that's covering that cavity. And then there's always going to be cartilage on both sides of the joint. So both bones that are coming together are going to have a cartilage end cap to them, right? Let's see. What we're also going to find there, obviously synovial fluid inside the joint. We're going to find reinforcing ligaments that prevent the joint from going too far in either direction. And then we're also going to find nerves there. So nerves are good, right? Nerves are going to be parts of joints. What do nerves do? They are our warning signs that something bad might be happening. Nerves are part of joints, for example, to tell us if we're doing something wrong. Like if you're overextending and then you feel a lot of pain, that's a nerve giving you a warning sign to stop what you're doing, right? And then we also have blood vessels associated with synovial joints. Oh, let me capitalize that J. There we go. That's better. Okay, other structures. All right, so other structures can include a meniscus in the knee, for example. So C-shaped cartilage pads, which we will talk about here in a second. We have a big one and a little one, a fat one and a skinny one. When it comes to C-shaped cartilage pads of the knee, the meniscus. Other structures also include fatty pads that help cushion. And bursa. So bursa are small fluid pouches. They're like this thick, rubbery, squishy, bouncy fluid. Not really runny fluid, right? And that's what gives us cushion. Bursas are pretty much all over the body. We'll talk about it a little bit more when we talk about bursitis. But they're separators where different things rub. So between bone, bone, skin and bone, to add an extra layer of cushion. Now bursitis is going to be inflammation of the bursa, and that can happen from injury, prolonged pressure, from repetitive motions, different things like that. And we'll talk more about that in a second as well. And then we have tendon sheaths. So tendon sheaths are protective tubes around some tendons, like around the fingers, for example. I don't know if you guys have ever heard of trigger finger, but that is when a finger has been bent and can't straighten back out. So that's actually caused by a knot in the tendon that won't allow that finger to straighten back out. And tendon sheaths are protective tubes around some of those tendons. Okay, so different types of synovial joints. So we have plane joints. Those are going to be flat and slide past each other. So these include carpocarpal joints and tarsotarsal joints. So carpocarpal, what is that? What does that sound like? It sounds like two carpals, right? And that's exactly what it is. It's plane joints allow two carpals to slide next to each other, like in your hand and your foot. Yeah, right here in this image. So plane joints allow these two carpal bones to slide right next to each other. Hinge joints. So hinge joint is right here. It does exactly what it sounds like. Think door hinge. These are going to be in our elbow. These are going to be in our IP. You're going to see IPs a lot. IP stands for interphalangeal, and that just means between the phalanges, so between the fingers. So think bending of the finger. That's a hinge joint as well. Pivot joints. So pivot is going to be right here. Pivot joints are going to be between the C1 and C2 vertebrae. Think rotation. And it's going to be between the proximal radius and ulnar joint. So think about turning your hand up and down. You're pivoting, you're rotating. So those are our pivot joints. Condyloid joints, so right here. So condyloid joints are associated with condyles, which are little knobs that roll under. So think little knot on the bottom of your head, little knobs on end of the radius. Radiocarpal joint is going to be between the radius and the wrist. And so that is a condylar joint or condyloid joint. Also, they're going to be between MCPs. You're going to see MCPs a lot. So remember what that stands for. Metacarpal phalangeal joints, right? Metacarpal phalangeal joints. Call them MCPs for short because that takes forever to write out and say. But that is the joint that's going to be between the hand and the finger bones. So between the metacarpals and the phalanges. Don't get these confused with interphalangeal. Interphalangeal are between the phalanges, bending the fingers. Metacarpophalangeal, so MCPs are going to be between the hand and the fingers. Okay. All right. So we also have saddle. So saddle joints are going to be right here. Saddle joints are going to be associated with thumbs. So think about how you move your thumbs backward, forward, sideways. So these are called carpometacarpal joints. So between wrist and hand bones that lead to the thumb specifically. Okay? Don't confuse that with MCPs or IPs. MCPs are condyloid. IPs are hinge, bending fingers like a hinge. And then saddle is going to be carpometacarpal. So wrist, hand bones that lead to the thumb. Okay. And then ball and socket. That one's the easiest to remember. Most of us already know the ball and socket joints. Those are going to be the shoulder and the hip. Ball, socket. Okay. All right. So when we talk about complex joints, we think different things like the knee. So we're going to talk about the knee and the shoulder as our complex joints. So there's complexity to them, right? There's a lot going on in the knee. We've got ligaments, we've got cartilage, we've got everything, right? All right, so we're going to talk about it. So the knee has 3 types of joints. It's got plane joints, hinge joints, and condyloid joints. The end of the femur actually has 2 condyles that articulate with the tibia, condyloid. Your knee, think about how it hinges. You can bend it, you can straighten it, hinge joint. And then plane, so when you're standing, you can actually slide the femur on top of the tibia when you're standing. So think about like if you're just kind of moving like to look behind you or something. Your femur can slide on top of your tibia a little bit. It's not going to go too far though because you've got a bunch of ligaments that prevent you from doing anything that's going to injure yourself. But that's plane. So that's the plane joint. Hinge, bending your knee, straightening your knee, and then condyloid, the end of the femur has 2 condyles that articulate with the tibias. That's where our condyloid comes in. Like I was saying, meniscus. So the meniscus that is in your knee has 2 cartilages that are C-shaped. You have a wide one, which is the medial, and then you have a skinnier one, which is our lateral, our tight C. So the medial meniscus is going to be a wider, thicker C. The lateral is going to be a tighter, skinnier C. And then we've got lots of ligaments. Bunch of ligaments in the knee. The more complex a joint is, the more ligaments it will have. So medial is going to be inside of the knee, right toward the midline of the body, medial. Then we have lateral and lateral collateral, which is the outside. We have the ACL and the PCL. Most of us have heard of this one just in vernacular. ACL is our most common injury. That's the anterior cruciate ligament and the posterior cruciate ligament. We have a VMO that runs on the outside of the knee down to the head of the fibula. So that is our vastus medialis oblique. And it's not actually a ligament. It is actually a muscle that we will talk about in the muscle lecture. But we do talk about it in our ligament section because it is acting as a ligament. So VMO runs outside of the knee down to the head of the fibula. And then we have our patellar ligament. So you know when you're sitting on a doctor's table and they're pulling out a rubber hammer and they hit right below the kneecap to see your knee jerk reflex? They're actually hitting that patellar ligament. So that's where that is located. And you can find all of that in these two images, anterior view here and posterior view here. So there's that patellar ligament right there. There's our ACL anteriorly and then our PCL posteriorly. Lateral meniscus, which you can't really see that. It's a C shape in this image, but know that the lateral is a skinny C and then the medial is going to be the thicker, bigger C. And fibula, tibia, femur up here, patellar surface right there. But anyways, injuries associated with the knee. So some of the most common ones are MCL, which is your medial collateral ligament tear. That happens when an outside force pushes the outside of the knee inward. So these injuries happen a lot in soccer. They also happen a lot in football. If somebody gets tackled from the side, that can push their knee inward and that can tear the MCL, right? So think about how the knee goes inward and how that tear could happen. ACL tear, most of us have heard of this one. This is our most common knee injury. The ACL, the anterior cruciate ligament, keeps your knee from hyperextending, but if your knee hyperextends anyway, that's exactly what's going to tear. And yeah, this one's the most common. Basketball players, football players, soccer players, basically any sort of sport, ACL tears are really commonly associated with. PCL tear, so this one does the opposite, so posterior cruciate ligament. This one happens a lot in motor vehicle accidents. So if you ever see MVA, that's a motor vehicle accident. So if if somebody hits you head on, your knee can get crammed into the dashboard and that can push too far into the tibia. And that's actually what would tear our PCL there. That one's not going to be as common though. Okay. Another complex joint is going to be the shoulder joint. We pretty much have a meniscus in the shoulder as well, but we don't call it that, right? We call it a labrum. It's essentially the same thing. It's a small cartilage pad inside the glenoid, inside the socket. It makes a taller ridge around the glenoid socket, and it makes it a little bit more stable, which is good. Rotator cuff muscles. If you're ever taking a standardized test for anything related to muscles, joints, etc., you're going to be asked to name the muscles that make up the rotator cuff, right? And this is it. This is an easy way to remember it, is sit-ins. You're going to see sits a lot, S-I-T-S, but sit-ins, will help you remember the teres minor, not major. So supraspinatus, infraspinatus, teres minor, not major, because there is a teres major, and then subscapularis make up our rotator cuff. Know this. You will be asked, and remember that it's not major. Remember to read the question completely as well. And then dislocations. So dislocation of the shoulder is very common, unfortunately. There is a part that isn't encased in a ligament, and that part is going to sit in the front of the armpit. Sits pretty unprotected. So if your arm is jerked up and backwards, the head of the humerus can actually pop right out of the socket. This type of injury usually takes 12 to 16 weeks of physical therapy after surgery to correct, right? To make a little bit stronger after, dislocating completely. In older folks or people with some degenerative issues, it can actually take up to 6 months to get better from a dislocated shoulder injury. A little refresher now on fractures and other injuries. So you guys remember a transverse fracture right there? This is just from our last lecture. Oblique fracture right there. Common unit fracture, you can kind of see where all of that is happening. Green stick fracture right there where it doesn't go all the way through. Stress fracture, so from repeated this person's probably a runner. Stress fracture to the heel. We have a pathologic fracture right there, probably from something like cancer, right? All of these are different fractures that we already discussed, but now we've talked about joints. You kind of know how everything articulates. That's just a quick little pop quiz in the middle of a joint lecture. But other skeletal injuries. So we've had fractures, etc., etc. You remember we talked about how it's better to break a bone than to tear cartilage? Well, that's because cartilage is avascular. There's no vasculature. So it can take a really, really long time to heal, if ever. And that includes, when we say that, we're including ligament in there, right? So cartilage, ligament, very avascular, unlike bone. So bone will heal a lot faster than if we were to tear cartilage or have an injury to any of our ligaments or anything like that. So we actually would prefer to break a bone rather than to tear cartilage because we'll bounce back a whole lot faster from a bone injury. But these are still characterized as skeletal injuries, so we're going to go over them. We've already discussed ligament tears, so MCL, ACL, PCL. So like I said, MVA, you'll see that. That stands for motor vehicle accident. Let's talk about cartilage tears. So, like I said, long time to heal, if ever. The meniscus and the labrum are the most common cartilage tears. Sprains. So sprains and strains are different. Don't get them confused. Sprains with a P, we're talking ligament. So when you sprain an ankle, we are spraining our ligament, right? We strain muscle. So don't get those confused. Strain with a T, muscles. Sprain with a P, ligaments. And that can happen from overstretching, like if you're just walking and your ankle rolls, right? We just sprained our ankle. Dislocation or luxation. Luxation is what we used to call it, but pretty much that is stayed in the past. We literally only call them dislocations now, and that is a complete separation of a joint. So like we talked about dislocating our ball and socket just a minute ago, where we don't have any protection in the front of our armpit region, right? That's a completely separated joint. That's a dislocation. A subluxation, so sub, think about what sub means, like subcutaneous, that's under, right? So under luxation, so partial dislocation of a joint. So we use dislocation as a completely separated joint, subluxation as a partial dislocation to a joint. So it's slightly out of place. You've tweaked it just enough that it can be really annoying to a specific nerve. This is where chiropractors come in a lot of the time. And then osteopathic doctors also deal with subluxated joints a lot. Bursitis. So, like I said, bursa, that's that cushion that separates muscle from bone or bone from skin, blah, blah, blah. It's that gummy-like cushion. That's bursa. Bursitis is if that gets inflamed. Bursa are everywhere. Hips, shoulders, elbows, knees, everywhere. Bursitis happens from either hard trauma or a lot of repetitive stuff. A lot of friction. Things like that. Tendinitis is almost always chronic. That is inflammation of our tendon sheaths, and that's from overuse. So you're doing the same thing over and over and over and over and over again, day in, day out, and it can be anything. Seamstresses can get tendinitis. Chefs can get tendinitis from doing the same thing over again. People who work on a line in a factory can get tendinitis from doing the same wrist motion over and over again. If they're moving one thing to a different line, just doing that same motion over and over again can cause inflammation of tendon sheaths. And like I said, it's almost always chronic tendinitis. Arthritis is a big one. Inflammation or degeneration of joints. There are actually 13 different types of arthritis. We're going to talk about 3. So osteoarthritis is also called degenerative joint disease. And this typically affects IPs, so interphalangeal joints, or our fingers. Crepitus is that crunchy sound when bending. Osteoarthritis can happen in the neck, so if somebody is moving their neck, it can sound like sand rubbing, right? And that's that crepitus. That's what that means, and that's what osteoarthritis or degenerative joint disease is associated with. And then Hebron's nodes, those are the small bumps that come up on finger joints, and that's overgrowth of the joints, and that is what people with osteoarthritis unfortunately have to deal with. With OA or DJD though, usually one side is going to be worse than the other, so the left hand might be worse than the right hand or something like that, whereas in RA, which is rheumatoid arthritis, it's usually bilateral, which means both sides of the body it's usually going to be the same on. Rheumatoid arthritis is mostly in women ages 30 to 50 years old, but it can be younger or older. This is just most commonly. And this is the rheumatoid arthritis is crippling, where the fingers start twisting and bending sideways. It usually happens at the MCPs. So remember, we were just talking about the metacarpal phalangeal joints, MCPs for short. And it's basically where the fingers hook onto the hands, where you're gonna see a lot of rheumatoid arthritis. My aunt has RA, and she had to retire early from being a chef for decades of her life. Again, that one happens mostly in women. Gout is mostly in men. Gout happens when uric acid crystals are depositing into a joint, and they cause that joint to swell up huge. Most commonly, this happens in the big toe. It can also happen in elbows and knees. With gout, folks have to change their lifestyle, or the pain will be worse from alcohol and red meat consumptions. You don't want to deposit any more uric acid crystals than you already have in the joints, and consuming alcohol and red meat can make that a whole lot worse. So folks with gout have to do a big lifestyle change so that the joints don't literally get eaten away. And then we have Lyme disease. So Lyme disease is a bacterial disease transmitted by deer ticks. Typically, they have to be on you about 36 to 48 hours. Some people say 24 hours. But these can cause joints to degenerate. It's severe joint pain. People with Lyme disease typically exhibit symptoms of flu. They always have a rash, and they always have severe joint pain. And then bone disorders, we already talked about these with rickets, osteomalacia, and brittle bone disease, and osteitis deformans, which is Paget's disease. This is just a little refresher. All right, and then these are the motion examples: flexion, extension, flexion, hyperextension, hyperextension, extension, flexion, hip flexion, knee flexion, extension, abduction away, adduction back in, medial internal rotation, lateral external rotation. So you can just go over these, look through these again, just to remind yourself of the different types of motion, because you are going to be asked to know these on the quiz. Okay, that's all I got. Thank you.